Hello, and thanks for tuning in. I'm Tom Dardis, a paramedic for Woods Ambulance, and today we'll be discussing ketamine and its use according to current guidelines and mass OEMS protocols. Pharmacology, the indications and contraindications of its use, dosing, cautions, as well as pearls and pitfalls of ketamine overall. Ketamine is known primarily in the veterinary world. It grew popular as a recreational drug in the early 2000s and has had many nicknames. It's also known by various trade names such as Ketaset, Vetalar, or Ketalar. Vet offices are generally where recreational users obtain the medication. Ketamine is a Schedule III medication, same as Ativan, that has both anesthetic effects and sympathomimetic effects. It works by interrupting the pathways in the brain that separate reality and can affect the fear centers by blurring those lines. It usually works within 30 seconds when given intravenously and within a couple of minutes when given intramuscularly. It generally lasts for about 20 minutes intravenously and can last up to 2.5 hours, especially when given intramuscularly. Due to its sympathomimetic effects, tachycardia and a bump in blood pressure can occur. This usually maxes out between 10 and 50% above baseline. The sympathomimetic effects generally last as long as the half-life when given intravenously, or approximately 15 to 20 minutes. It is absorbed into the tissue from the CNS and processed through the liver. Most of it is excreted through the urine, so keep that in mind with patients who are renally impaired. While the color of the solution may darken to a yellowish tint secondary to light exposure, it does not affect its potency. But discard the medication if any precipitate is noted in the vial. Do not mix with barbiturates, such as phenobarbital, as this will cause precipitate in the syringe or tubing. Be sure to adequately flush a line containing such a medication before administering ketamine or use a separate IV site. Ketamine works best when combined with another medication such as fentanyl or a benzodiazepine. It can be used as a primary agent and is often used for procedural sedation such as RSI or cardioversion. When other analgesia is shown to be refractory such as fentanyl, the use of ketamine will potentiate those influences, thereby increasing its effectiveness. Use caution in polypharmacological conditions, especially in the presence of street drugs. It can be used as an infusion for analgesia and sedation in the longer term, such as a vented patient. So among the contraindications for ketamine is obviously a known allergy to the medication or a sensitivity to ketamine. Patients with a significant hypertension whose condition would pose a hazard if that blood pressure was elevated any further is something to certainly keep in mind. Head trauma, however, is become a relative contraindication. There are some that still feel that ketamine should not be used in this realm. It was thought actually that the elevated ICP was secondary to the possibility that ketamine may increase the CSF volume after administration. However, newer literature has listed this pretty much as a myth now at this point, and therefore that's why it's a relative contraindication. As a matter of fact, ketamine is the induction agent of choice, even in trauma. It's found to be more of an issue with patients with a known existing brain mass. Therefore, another contraindication then would be a known intracranial brain mass. Psychosis or schizophrenia are noted to be relative contraindications. Early research showed that in the subanesthetic doses, hallucinations could be worsened for a transient period of time. Newer research shows that there's no long-term effects with the usage of ketamine in these conditions. The key is to use ketamine as a second-line sedative with something like Versed or propofol. Haldol is shown to be effective even in children. However, it's important to remember that in Massachusetts, ketamine is not authorized for use in behavioral emergencies in children. Ketamine is okay to use on its own, but it does work best when combined with other agents. The Massachusetts Office of Emergency Medical Services protocol allows for a single choice when using chemical sedation or restraint for a behavioral emergency, so medical control must be contacted for additional medications if the patient does not respond to ketamine alone. So caution should be exercised in use of ketamine in a stroke patient. This is because in the field especially, we cannot diagnose between a clot stroke, a head bleed, or perhaps an unknown pre-existing mass that the patient may not be aware of, such as a brain tumor. Elevated intraocular pressure, such as patient receiving injections for macular degeneration or other known disease processes that may increase intraocular pressure. Thyrotoxicosis, or hyperthyroidism, also known as Graves' disease, affects 1 in 100 people. It's an autoimmune disorder where large amounts of thyroid hormone is created without control, causing weight loss, nervousness, irritability, intolerance to hot weather, excessive sweating, shakiness, and muscle weakness, and may be accompanied with tachycardia or goiter, which is thyroid enlargement, fine tremors of the fingers, and hot, moist, velvety skin. Bulging eyes are also common. It's thought that where ketamine releases the catecholamines, the effects can exacerbate that condition. The same can be said for coronary artery disease or congestive heart failure. But with any of these comorbidities, caution should be taken with any medication that we are giving. In the case of alcohol abuse or chronic alcohol abuse, the issue there is the possibility of hepatic impairment, remembering that a portion of this medication is processed through the liver. The effects of ketamine are very much dose dependent. That is, what you get for effects will be determined by the amount of ketamine you give. In the case of an RSI, or rapid sequence intubation, the dose is roughly 2 milligrams per kilogram over 60 seconds. This can be as much as 4 milligrams per kilogram, however. Remember, if given too quickly, you can have a transient apneic period that can last as long as 20 seconds. When used in sedation, in combination with other agents such as Versed or Valium, the likelihood of emergence delirium may be decreased. This should not be confused with excited delirium. Both of these conditions will be discussed later. The maintenance dose is between 0.1 and 0.5 milligrams per minute. If you take 10 milliliters of a ketamine concentration of 50 milligrams per milliliter, or 5 milliliters of a concentration of 100 milligrams per milliliter, and place it into a bag of either normal saline or D5W, it will give you a concentration of 1 milligram per milliliter. The average maintenance infusion will normally be between 100 and 500 milligrams per hour. As previously discussed, ketamine is not approved for the use of behavioral emergencies in children. For adults, the Massachusetts OEMS protocol states 4 milligrams per kilogram used intramuscularly only. Use caution in patients over 70 years old and cut the dose in half, which would be 2 milligrams per kilogram intramuscularly. The maximum dose when doing your math is no more than 400 milligrams. Your single dose, your first dose, is on standing order. Any additional doses that may be required need medical control consultation. As we look onto Massachusetts OEMS protocol for pain management, you will notice that under the standing orders, ketamine is for adult use only. It is best practice to use other analgesics first, and as we discussed earlier, adding ketamine to that regimen will potentiate its effects and work much better for you. The dose for pain for ketamine is 0.15 milligrams per kilogram, either intravenously or intraosseously. Remember that a rapid push may result in an undesired effect, so push it slowly. You may repeat it in 1 to 2 minutes and use 0.3 milligrams per kilogram if administering it intramuscularly or intranasally. When using ketamine for procedural sedation or sedation of an intubated patient, there are some things we need to keep in mind. First and foremost, end-tidal carbon dioxide monitoring, or capnography, is considered to be best practice. As far as Woods Ambulance is concerned, as well as the state of Massachusetts, it is the standard of care. Remember when we are administering the medication that we want to do it in a slow manner for reasons previously discussed. For a patient that's already been intubated, our dosage is going to be 1 to 2 milligrams per kilogram, IV or IO, up to 100 milligrams. You may administer half of your initial dose in 5 minutes, twice, to a maximum of 200 milligrams total. Contact medical control for additional doses. On a transfer, a patient may be on an infusion of a different dose per the physician's order. Generally speaking, such an infusion can range anywhere from 200 to 500 milligrams per hour. When using ketamine for cardioversion, please remember that in terms of paramedic standing order, ketamine is again for adult use only. Your IV or IO dose will be 0.1 to 0.5 milligrams per kilogram. If doing it intramuscularly, then the dose will be 1 milligram per kilogram. Repeat in 5 minutes as needed to a max of 2 milligrams per kilogram. It is very important to remember in your dosing that if you're using a concentration of ketamine that is 100 milligrams per milliliter, it must be diluted in either normal saline or D5W before you can use it intravenously. This is very important. Please remember that a concentration of greater than 100 milligrams per milliliter must be diluted before intravenous use. In the next slide, we are going to review a chart that was put together by a Dr. Ruben Strayer, who is at Mount Sinai Hospital and came up with the New York Guide to Dosing. The effects of ketamine are dependent on its dosage. Therefore, whatever effect you want is going to be determined by how much ketamine you are going to give. At the top of this chart, the 10 to 20 milligram range, which is that 0.15 dosage for pain, your patients will remain conscious, however will express pain alleviation. The recreational level, which is roughly 30 milligrams or 0.2 to 0.5 milligrams per kilo, this is where a patient is conscious but may have a stoned appearance. This is the level that the recreational user looks for. The next dose up is called partial dissociation, roughly 50 milligrams or 0.4 to 0.8 milligrams per kilogram. This is the area of ketamine that we need to avoid. This is where patients are conscious, sort of aware. Unfortunately, because of the disassociation and the fear centers that we talked about previously, patients may experience very vivid and often terrifying both visual and auditory hallucinations. This will cause a safety hazard for both the patient and the provider. Please avoid this level of dosing. Ketamine is one of those drugs where a little bit more is better than not enough. At 100 milligrams or greater than 0.7 milligrams per kilogram, this is the area that we want patients who are intubated. This is where they are completely dissociated. They are unaware, they may be awake, but not necessarily conscious. We refer to this as the K-hole. This is the level that we want patients to be at. Patient doesn't feel anything, doesn't form any memories, but they do sometimes report some vivid dreams. 1,000 milligrams sounds like a lot of ketamine. Studies have shown that ketamine doses as much as 10 times the recommended dose have shown to not have any intensification of its effects. It just simply makes the effects of the drug last longer. Therefore, it is thought that ketamine has a pretty good margin of safety. Ketamine is one of those medications where sometimes giving a little too much is better than not giving enough. A reaction to ketamine that a small percentage of people do sometimes experience. Shortly after the administration, he begins to panic and hallucinate. There is a phrase that we talk about that says, how they go down is how they come up. This will become important in a later discussion. So in this case, the patient never completely went down, so the disassociation turned into a form of delirium, similar to emergence delirium, not to be confused with excited delirium. And we will talk about that particular complication later. At the hospital, you are going to see a myoclonic reaction in his extremities and his face with nystagmus. You'll then see the reversal of the adverse effects after the Versed is administered.
Listen, was anyone with you when you fell off the wall? Nobody, you were alone, yeah?
Yeah.
Okay. Did anyone see him fall? Do you know if you were knocked out?
I don't know, I can't remember.
Well, listen, you've made it from the edge of the wall to here. You're quite a way away. You dragged along, did you? What, using your arms?
Yeah.
Dan's quickly able to establish that Paul does not have signs of a head injury and assesses the damage to the rest of his body.
Yeah, he's got a fracture dislocation of that ankle at least. Listen, try to relax for a minute, because if I don't get this needle in, I can't give you any pain relief, all right? Now keep nice and still, a little scratch coming up, okay?
He is in agony. Dan's giving him a drug called ketamine. It will provide him with the potent pain relief he needs.
Hang on, it has only just gone in, hasn't it? Hold it. Now listen, Paul. Paul, can you hear me?
Yeah.
I've given you some painkillers. You might not be feeling that they're making a huge difference, but they are. We're going to roll you over. We need you flat on your back, and you're going over with us now onto a cold stretcher.
But something unexpected happens.
I don't know what's happening to me.
Okay, we're going to sort you out. Just giving you some very strong drugs, all right? Most of it.
I'm dying.
So let's what we're trying to do now.
Paul is experiencing an extreme reaction to ketamine.
Ready, brace, and turn.
It's causing him to hallucinate badly. These reactions are extremely rare and are rarely remembered.
And roll down.
I feel like I'm dying. I feel like I'm dead. I'm dead.
No, you're not dead.
I'm dead.
About 1 in 50 patients suffer these adverse reactions.
I'm dead.
I'll get that back on, and then we're going to pull that.
Dan has to pull Paul's severely dislocated ankles back into position.
Hey, listen. I've got to give your ankle a little bit of a tweak, okay?
If he doesn't act quickly, this could lead to lasting damage or even amputation.
Could you just hold him for a second? Okay, well done. Try and relax. Well done. Good job.
What's happening to me?
We're lifting you up now.
Now?
Yeah, now. Right
We're
now.
in there. Oh.
Super. That's fabulous, Paul. You've done brilliantly, mate.
Feel right there, mate, all right? You got an alien.
I normally look like that.
Yeah, sorry.
Drugs obviously working off then.
Let's go.
To assemble a trauma team for a patient that we've just been given notification of.
Paul, what exactly is hurting you, yeah?
My legs.
Your legs what? Right, okay, well wiggle your toes now. And wiggle the other toe too. There you are. They're still there.
Gareth will lead the trauma, but he must also ensure that Howard continues to receive minute-by-minute care.
Ken's one of the med regs here, okay? I'm just going to hand over to him for a few minutes while I just do this trauma next door.
What hospital am I in?
You're in the hospital Royal London, okay?
The Royal London is home to the most specialised trauma unit in the country. It may receive up to 4 trauma patients in any shift.
Who's team leader?
Me.
Just a bit of oxygen, okay?
Paul is still suffering the adverse reaction to ketamine.
Where am I? I don't know where I am.
Just give him 2 milligrams of Medaz.
Very happy for handover.
Okay, shut it out.
This is Paul Whitehall. Paul is a 26-year-old gentleman who fell 20 foot off a railway siding, landing on grass. His obvious injuries from top to toe are that he had a fractured dislocation of his right ankle. He also had a fracture of his left ankle. He's had in total 100 milligrams of ketamine, but he has been undergoing a quite marked ketamine reaction, including visual hallucinations.
Thank you. Okay, can we just have 3 people down each side? Paul, if you could stay that side, stay where you are. Just brace his chest there.
It's important to quickly build up a picture of Paul's injuries to see if any are life-threatening.
We're just taking x-rays of his spine now, and to make sure he hasn't damaged that. Because we know from what we call mechanisms of injury that if someone's landed on their feet, if you look at those patients, they have characteristic injuries. They begin at the ankles, you can have certain fractures of the knee, then of the pelvis, and then of your spine. It's all due to the fact that you land on your feet and the shockwave goes up your body. So it means, to go on, just shout, don't wait for them. People come in with atrocious fractures of their ankles, screaming in pain like this, and actually the fractures of their lower back.
Breathing
fine, circulation fine.
Paul's x-rays confirm Gareth's suspicions about a back injury.
This guy has fractured one of his, I'm not sure if it's a lumbar or thoracic vertebrae on that film, which just shows you he's not complaining of any pain, he hasn't mentioned it to any of the doctors. So we're going to have to scan that now, because it may actually be unstable looking at it, which means it may require surgery, but a scan will tell us a bit more.
Okay, so towards the end of that, you could see that the Versed that the physician had ordered was taking effect, and his reaction to the ketamine was beginning to dissipate. In this video, you will see the rapid onset of ketamine when given at 2 milligrams per kilogram. You can expect to see a similar result during a rapid sequence intubation. Note the occasional nystagmus. Also note the patient's respiratory status and the use of capnography to monitor respirations. A follow-up half dose is given as the patient begins to wake up. You will note that atropine has been set out, should the patient produce excessive secretions. Ketamine can cause an increase in salivation, but it rarely requires any pharmacological intervention. It's usually mitigated with suction alone.
On your blue button, okay? That's okay. No worries. No worries. Just water. It's okay.
A timeout checklist is performed to ensure everything is ready for the procedure. The patient is confirmed as the correct patient, the medications and the dosages are rechecked, and all of the required equipment is present for the procedure.
It's just water. Calm down.
It's just water.
It's just
Stick on your blue button.
Calm down.
I don't want no water. It's just a little bit. Just a little bit, bud.
Don't touch it.
Are you guys ready?
It's just water.
We're ready.
All right.
We got suction on. We're all
Just
set.
some more.
Calm down.
What?
We got.
The acronym SOAP-ME is a quick checklist that should be performed before any conscious sedation or even intubation to ensure that you have everything you need for the procedure and be prepared for any complication that may arise.
The suction on. I got it on.
It's just water, Demaya.
And we'll put that padding under his shoulders.
Look at the light.
Look at the fancy
Look at the
light.
light. Look at the light, Demaya. Look how big it is. Calm down. It's water. Calm down. It's gonna make you feel all better. Look, you on camera.
Good job, big boy.
You're a big boy, remember? You taking pictures. You're a big boy. Come on here, baby. Come on here. Sweetie, mommy right here.
All right. There we go.
Here we go.
right.
Note that the patient appears conscious, but isn't moving.
Perfect. Perfect. Irrigating the wound on it.
Yeah, this is gonna get in your way, but we'll attempt.
I need a challenge.
Yeah. Keep balancing tonight.
So you think the superior labial artery was cut and was in spasm, and he's bleeding a little bit more, and he's awake too. So we're gonna, or he's waking up a little bit. So we're gonna give him half of that. I'm gonna give him 9 milligrams. Yeah, to have another one ready. Now we got the entitled CO2 working. You're doing all right?
I'm doing fine.
Okay. Sometimes parents pass out, so you're doing good though.
I've done that almost once before.
Did you? Yeah.
Yeah.
Do you think we got the edges together pretty good? All right. He's starting to move his little arms. Oops, oops. Keep the hands out of there, big guy. Let's give him his medication. Let me suck him out here for a second.
Okay.
All right, so we're getting close to the end, yeah? Waking up.
Hi, my love. Hey,
He's
big
still got a
boy.
little nystagmus what's going on in those eyes, but he's
Hey.
waking up.
Hey, it's all over. You're a big boy. You're my soldier. You know that?
You did good.
Cardiac functions will be monitored during the procedure. Recognize that rapid administration of ketamine will cause a transient apnea that may last as much as 20 seconds. Obstructive sleep apnea patients may present longer post-procedure. An increased heart rate and blood pressure, transient up to about 15 minutes, and may be on average between 10 and 50% of the baseline measurements. Overdose studies have shown that even dosages high at 10 times the recommended dose have noted prolonged recovery, but not a prolonged effect. Obstructive sleep apnea patients may have apnea periods after the painful stimuli of the procedure is complete and the medication is still present. Capnography must be used to monitor the patient's respiratory status. Apnea may be more prevalent if the patient has other medications or street drugs on board. You must continually monitor the airway and the patient's breathing and intervene as appropriate. This may include the use of a BVM. Some serious complications include respiratory depression. Laryngospasm is often talked about with ketamine, but actually only occurs in 1 to 2% of cases. Increased ICP with the use of ketamine has more or less been debunked with recent studies. Increased intraocular pressure was discussed earlier. Hypotension can be pronounced if a patient's shock index is high, which is something we'll talk about here shortly. Bradycardia can also occur. Arrhythmias are extremely rare. Hallucinations can occur, especially in patients that are not adequately medicated. Myoclonus is a condition that appears to be seizure in nature, but actually is not a seizure, and we'll talk about that momentarily. Anaphylaxis is a complication with any medication that a patient may have never had before. Emergence delirium can occur as a patient begins to wake up from the sedation, and we'll talk about that specific complication here shortly as well. Some other common complications that can occur, tachycardia and hypertension. As discussed earlier, this is often transient and no more than 10 to 50% above baseline, and sometimes actually a desired side effect. Normal tachycardia and hypertension is less than 20 minutes, essentially the duration of the half-life. Sialorrhea, or excessive salivation, is something that can occur but is usually manageable with just suction and rarely requires any pharmacological intervention. According to MCRIT, which is Dr. Weingard, an individual who runs the podcast known as MCRIT, his experience noted that the sialorrhea is manageable with rarely requiring atropine or other medications such as scopolamine. Anorexia can occur, but it's usually in chronic abuse patients. Nausea and vomiting, double vision have also been reported. The nystagmus can be seen in the two videos that we just witnessed and can be quite pronounced. Fasciculations can occur but do not occur very often. Depressed reflexes is a side effect of the medication that we will generally see. Hallucinations can occur when underdosed and as discussed previously. Bradycardia and hypotension can occur in patients with very high shock indexes, and we'll discuss that again shortly. Cystitis or UTI is also a possibility, as remember that the majority of the medication is excreted through the urine. So myoclonus was listed as a complication, but what actually is it? Myoclonus is a rare complication. It's often mistaken for a tonic-clonic seizure or dystonic reaction, but it is a reaction that is peripheral in nature and doesn't come from the central nervous system. It actually stems from the spinal cord. Treatment, however, is the same as a seizure by use of benzodiazepine. It can also be mitigated by the use of total neuromuscular blockade, such as the use of a paralytic such as rocronium, vecronium, pavilon, and the like. As we revisit this portion of the previous video, you can see the myoclonic reaction in his extremities. This is not seizure activity, but it's treated the same, with either additional ketamine through protocol or med control, or with the addition of a benzodiazepine, such as Versed. So here you can see the shaking in his hands. This is the myoclonic reaction and can be quite pronounced. He continues to experience the myoclonus until such time as the Versed that was given takes effect. As discussed earlier, laryngospasm is a rare complication that occurs between 1 and 2% of sedations. In one review, 2 out of 11,589 patients had an episode of laryngospasm with ketamine. It can usually be overcome with the use of a BVM and Larson's maneuver, which we'll go over in a couple of slides. Total neuromuscular blockade is rarely required, unless, of course, a rapid sequence intubation is the ultimate goal. Larson's maneuver is simply a pressure point that is located at the TMJ, as pictured here. When opening the airway and maintaining a manual opening of the airway, you take 2 of your fingers and place them into these pressure points and push inward while holding the BVM in place. As another individual begins to bag your patient, the combination of using the bag valve mask and this maneuver will often open the airway. So there's been a couple of times throughout this presentation we've talked about emergence delirium. This is not to be confused with the delirium that's become very popular in the media, or the type of delirium that is now no longer considered to be a cause of death by most medical examiners. We'll discuss it now. Emergence delirium should not be confused with excited delirium. Excited delirium is a condition that was considered as a cause of death, but is no longer accepted as such. It was observed to be primarily in the pre-hospital setting. There have been several high-profile cases where ketamine was used in a suspected excited delirium case, where the patient died and the EMS provider was charged in the death post-ketamine. Caution must be taken when using ketamine in such cases, as the patient may have other polysubstances on board that may interact with the ketamine and cause respiratory or cardiac arrest in unexpected and unpredictable ways. Emergence delirium occurs as a patient is waking up from sedation or anesthesia, partially due to the disassociation. Remember, how they go out is how they come back? This can be mitigated with the administration of a benzodiazepine, fentanyl, or an additional dose of ketamine. In the study that was mentioned in the previous slide, it was found that 5.3% of those in that study experienced this effect. The average incidence is 12% and is reflected in the product insert. The rate appears to be higher in patients over 80 with comorbidities and those pre-op medicated with benzodiazepine, beta blockers, and opioids. Normally, the episode occurs within 30 minutes of recovery and resolves after about an hour. It's not to be confused with post-operative delirium, which can last for days, nor should it be confused with post-operative cognitive dysfunction, which is a prolonged state of altered mental status and cognitive dysfunction that poses an increased risk of morbidity. POCD and POD are more prevalent in other forms of anesthesia gases and may have hypoxic causes while under those gases. One of the ways that we can determine how much of a risk a patient is for emergence delirium is how they go out. Loud auditory and visual stimulations can worsen the effect. Remember, the way a patient goes down is how they come up. If a patient is thinking pleasant, happy thoughts, they wake up that way. If they go down full of fear, then the delirium can be more dramatic. Remember that as a patient is coming out of it, that hearing is the first sense to return. So remember that as you're having your conversations around your patient. The mechanism that is responsible for hearing returning first is also responsible for auditory fear conditioning by exaggerating an inappropriate and heightened response to an auditory stimulus, which enhances the stress of the induced behavior. Therefore, if you have loud noises that are occurring as the patient is waking up, this can cause the patient to begin to hallucinate and induce the delirium as they wake up. Other possible causes of the delirium have been associated with elevated cortisol levels that correlate with a lot of these cases. Hypocapnia, or decreased end-tidal CO2, decreases cerebral blood flow through vasoconstriction. Prolonged episodes may damage this particular area of the brain and may be responsible for the exhibition of the emergence delirium. Hypercarbia increases CO2, causing acidosis that promotes an altered mental status, and therefore can induce this delirium. The catoputamen is a regional part of the brain adjacent to the ventricles believed to be responsible for the good feelings associated with safety and security. And remember, ketamine can interfere with that particular center. One predisposition to emergence delirium has been noted in hypoxic states, evidenced by myocardial and cerebral ischemia. So a patient that has been hypoxic for an extended period of time can have a higher incidence of the emergence delirium. So some of the risk factors for emergence delirium include patients that are less than 40 and greater than 64 years old. They appear to have higher incidence of emergence delirium in studies. Several of those studies note pediatrics less than 5 years old are susceptible to altered mental status on recovery as well. Diminished levels of acetylcholine, dopamine, norepi, and aminobutyric acid is found in the elderly and child brain development. ACH, remember, regulates the awareness and arousal that may account for the mental status changes and the increased risk of emergence delirium. There were some early studies that suspected that benzodiazepines may increase the risk of emergence delirium. However, numerous studies since then have found this not to be true and show actually a decrease in episodes when benzodiazepines are used in conjunction with ketamine. As previously discussed, some of the inhaled anesthetics used by anesthesia may increase the risk of emergence delirium, especially in children between 3 and 5 years old, it seems. The surge of cases are also noted in the use of these particular anesthesia gases. It's believed to be secondary to low blood solubility by these agents that promotes rapid awakening and therefore increase the susceptibility to emergence delirium. Remember, the way they go down is the way they come up. Fentanyl helps to slow the patient's wake-up time and mitigate the delirium. So as a patient's waking up, a little bit of fentanyl may help to alleviate the symptoms of emergence delirium, or using the fentanyl as a pain medication prior to sedating a patient with the use of ketamine may help with the reduction in risk of emergence delirium. So when being used for a procedure where fentanyl is also being used for pain as well, just don't be stingy with the fentanyl. The fentanyl will compound the effects of the ketamine and be a much better combination for your patient. Whenever a patient is under sedation, whether it is for a procedure or an intubation for, say, a transport, a vented transport to a tertiary care center, it's a good idea to make sure that you annotate the level of sedation that your patient is at during the transport. This is done through a sedation scale of some kind. The Massachusetts OEMS protocol book lists the Richmond sedation scale. Here in front of you, I am presenting you with Riker's sedation scale. Whichever sedation scale you are comfortable using is fine. However, remember that when you are documenting the patient's sedation scale, that you document which scale you are actually using. And you can see under this scale here, the number correlates with the symptoms that your patient will be exhibiting or not exhibiting, depending on how heavily sedated you have them. So when using the Riker scale on the slide before us, the goal for intubation is between a 1 or a 2. That's our treatment goal. That's where we want to keep our patients. For general sedation, we generally want them between a 3 and 4. General sedation is actually the level we want to keep them at for psychological emergencies as well. One study even noted that the use of Versed specifically at 0.03 milligrams per kilogram prior to the end of a procedure reduced the likelihood of emergence delirium, but without reducing the awakening time. So therefore, your patient was still able to wake up in relatively short order, however, with a less likelihood of the emergence delirium. Other things to watch for when using NSAIDs or opioids: pain is a well-documented factor in emergence delirium. The more pain that your patients are in when they go out, the more likely that a patient may experience emergence delirium as they wake up. Toradol actually has conflicting literature for its efficacy with regard to both pain management in these cases as well as the prevention of emergence delirium. Most literature suggests that opioids are best effective, fentanyl being our number one choice. Other things we use to help mitigate emergence delirium: clonidine, which is not available to EMS. It's more often used in the preoperative setting. Precedex is becoming much more prevalent in emergency rooms and therefore becoming more prevalent on EMS transfers to tertiary care centers. It shows great effectiveness with very reduced side effects. The biggest, of course, is the bradycardia. It is also not available to EMS on a regular basis. Ketamine is actually used to help prevent emergence delirium, strongly favored for that treatment, but it's mostly used as a pre-treatment for emergence delirium for inhaled anesthesia gases. In the next few slides, we'll discuss some pearls and pitfalls with regard to ketamine because, what could possibly go wrong? One of the biggest pitfalls with regard to ketamine use is the failure to recognize apnea post-procedure, but while a patient is still sedated. This is where I feel that the high-profile cases that were previously discussed that even caused EMS providers to be arrested, charged, and convicted failed to recognize. Another pitfall would be the failure to recognize the emergence delirium as it's happening and therefore make it more difficult to mitigate as the patient becomes more difficult to control. Use in TBI patients is known to be effective. Recent studies show that a patient with no pre-existing intracranial masses or intracranial fluids, such as hydrocephalus, have no adverse effects, and it's a good alternative in RSI patients with cardiovascular instability. Due to ketamine's sympathomimetic properties, it may reduce bradycardia and hypotension. One study noted no 28-day mortality rate differences with patients that were inducted with ketamine versus Versed. The use of ketamine in a controlled ventilation situation shows no significant increase in ICP. Monitoring of capnography is advised, along with total neuromuscular blockade to control ventilations. There seem to be higher incidence of increased ICP noted with patients who are spontaneously breathing. The use of ketamine in pregnancy is classified as a Class B intervention. It notes that there's no adverse effects in the first trimester. Second and third trimester information just doesn't really exist. Fetal harm is therefore possible, but not likely. The product insert notes placental passage of the medication was found to occur in pregnant dogs and monkeys. So use caution in these particular pregnant women and contact medical control if you feel that it's necessary. It can be safely used intramuscularly for procedural sedation because it has predictable durations. We know how long it's going to last, and we have a very well documented margin of safety with regard to its use. It provides safe and powerful analgesic effects when pain is refractory to other medications, with that simple 0.15 milligram per kilogram dose. Interestingly enough, ketamine has been found that it has some beta-2 agonistic effects that promote bronchodilation. This obviously is adventitious when we're talking about RSIing or rapid sequence intubating a patient that has asthma or COPD. It is the induction agent of choice in an RSI when hypotension is a concern. Dr. Richard Leviathan of Franklin, New Hampshire, who is also the inventor of the difficult airway class, referenced a 2011 clinical guideline as the definitive paper for ketamine in RSI due to its dissociative effects. There is a bit of an exception, however, when the patients are completely obtunded and profoundly hypotensive. In those cases, give the ketamine very slowly. A lack of sedation can be dangerous in an intubated patient. Remember, paralytics do not sedate. Ketamine, however, offers a good choice when total paralysis is not desired, as it covers both pain as well as sedation. The ACEP, Excited Delirium Task Force, discusses that as a tranquilizer, ketamine can be chosen for its predictable onset and duration with safety. It is effective regardless of the patient's size or strength. Dosages can be as high as 500 milligrams intramuscularly for a first dose. It's important in these cases to weigh the risk versus benefit with regard to increased heart rate and blood pressure against the dangers to staff and other patients, as well as bystanders with a combative psych patient that may require ketamine for sedation. When ketamine is used for psychological conditions, the patients need to be monitored. Another benzodiazepine may be required as a patient begins to wake in order to prevent emergent delirium. Remember, how a patient goes down is how they come up. Dr. Ruben Strayer of Mount Sinai Hospital of New York notes that the psychiatric distress that can be caused by ketamine is not dangerous and can be prevented by pre-induction coaching, in other words, help them find their happy place as they're being medicated, and that propofol can be used to manage hypertension. Dr. Strayer also notes to be careful in small doses where patients are not being completely put out and anticipate distress. The distress can be combated with other benzos, narcotic analgesics, or propofol. Just wait it out. Patients will simply metabolize the drug and come down from these distresses. He notes coaching as the med is being given, telling patients to think pleasant thoughts, such as imaging they were on a beach. It will be helpful because remember, as they go down is how they come up. So, the increased heart rate and blood pressure that ketamine is known for can be both a positive and a pitfall. One recent paper described 2 incidents of cardiac arrest after induction with ketamine during a rapid sequence intubation. But on resus.me, Dr. Cliff Reed cites other possible causes for these 2 incidents. However, one should still be aware of the possibility, as with any other medication that we give, that cardiac arrest is a possibility. So in order to prevent dependency or recreational use, and remember ketamine is classified as a Schedule 3 or Class 3 controlled medication, it's usually advised to treat it like a higher controlled narcotic. For the purposes of Woods Ambulance, as well as the state of Massachusetts, ketamine will be kept as if it were a Schedule 2 in the same class as morphine and fentanyl in order to prevent diversions. So shock index is a pretty important factor when we're trying to predict whether or not ketamine is going to cause us hypotension versus the hypertension that we generally look for in its usage. The general consensus shows that ketamine increases heart rate and blood pressure secondary to that catecholamine release that we discussed earlier, and again remember between 10 and 50% of the baseline. High shock indexes are conditions that appear to coincide when a patient's catecholamine stores are depleted and may account for these episodes, these issues. High shock index patients should be crash resuscitated first with things such as fluid boluses. So what is a shock index? How do we even find out what that is? Well, if you take the heart rate and divide it by the systolic blood pressure, this gives you your shock index. Generally speaking, a high shock index is considered to be greater than 0.9. In a study that was done in 2020, it was found that people with a shock index greater than 1 had a mortality rate as high as 22.7%. In a New England Journal of Medicine study showed that patients that were given ketamine for RSI that had a shock index greater than or equal to 0.9 had 26% of that group experiencing hypotension or less than 90 systolic versus only 2% in the group that had a shock index of less than 0.9. That's a pretty huge difference. 2%, 26%, and the only thing that separated them was a shock index of 0.9. The low shock index patients had an increase of heart rate by an average of 20 beats per minute and it increases systolic blood pressure of 16 millimeters. There doesn't seem to be any difference when compared to patients giving etomidate for intubation. So to all my EMS peeps, while we were doing this presentation, we covered all kinds of facets of ketamine that are both inside our protocol and outside of it. I did this in order to give you a better understanding of the medication so that we can see both the good, the bad, as well as a little bit of the ugly with regard to ketamine usage. Whenever we're using a medication, the protocol, or even a procedure, our protocol should be our guide. Whenever we're in a situation that seems to delve outside of those, medical control is always available to answer our questions. And whenever there's a doubt, you should always contact medical control to consult with them on the best course of action for a patient, regardless of that patient's condition, whether you're using ketamine or not. With that as our final thought, I want to thank everybody for listening and attending this presentation. At the end of this slideshow is a list of all of the references that I used to put this material together for your references. If you have any questions, feel free to reach out to me. Thank you, and have a wonderful day.